introduce Dr. Odutola Oyewo. Dr. Odutola received her foundational medical education at the Olabisi Onabanjo University, Ago-Iwoye, where she earned her Bachelor's of Medicine and Surgery degree. Her postgraduate surgical training began at Babcock University Teaching Hospital, subsequently at the Lagos State University Teaching Hospital, and went on to complete her junior residency and specialty training in urologic surgery at the University of Benin Teaching Hospital, and earned her fellowship of the West African College of Surgeons. She is an associate fellow of the National Postgraduate Medical College. She has been a life member of BMSS and has been providing bloodless medicine surgery services since 2018. Currently, Dr. Odutola Oyewo serves as the consultant urologic surgeon at the General Hospital in Ikorodu, where she manages a wide array of urologic conditions, including general urology, andrological, reconstructive, and oncologic urologic surgeons. With that, please give a warm welcome to Dr. Odutola Oyewo.
Good afternoon, good morning, everyone, once again. I'll be talking about bloodless care in uro-oncology today, and I'll be using the following outline. Mention the spectrum of...
Sorry, you can't see your slides.
What? Yeah.
What kind of sick is she?
Can you hear me now? Or can you see the slides now? Sorry.
We can hear you, but we not the slides yet.
Still not seeing the slides.
Come up here and test today or tomorrow.
Right. Just 1 second, please.
Sure.
And does she work tomorrow as well? Yes.
Are they up now?
Yes, your slide is on now. So you need to go to the title page.
All right. So good afternoon once again. I'll be talking about bloodless care in uro-oncology. And I will be using the following outline. I'll be mentioning the spectrum of uro-oncology surgeries and other causes of anemia in this subset of patients. Briefly talk about the pillars of bloodless surgery, and then dwell on the principles of management of bloodless care in urology. I'll share part of my local experience, and then I'll conclude. Now, cancer in the uro-oncologic patient and its treatment do often put a strain on patient's blood supply, from multiple causes: nutritional, renal impairment from obstructive uropathy, internal bleeding from a tumor, a bleeding renal tumor, a bleeding bladder tumor, a bleeding prostate CA, or even when they spread to the host bone marrow. These are all sources of anemia in the uro-oncologic patient. Surgery, more so in this group of patients, requires cutting through their skin, their organs, and other tissue that also result in blood loss. Now, more and more patients are concerned about the safety of blood. More people are more informed about allergic reactions, the fact that they can get infected from blood transfusions, and all these may turn slow down their recovery or even complicate it. Additionally, it's important to respect the rights of all our patients, including those religious groups such as Jehovah's Witnesses, whose beliefs prohibit transfusions. Now, the spectrum of uro-oncologic surgeries that are commonly performed: penectomy for penile cancer, radical appendectomy with retroperitoneal lymph node dissection, which sometimes can cause hemorrhage from the great vessels. We also have radical prostatectomy, which is done for organ-confined prostate cancer. We also have radical cystectomy, urinary diversion done for organ-confined bladder cancer, and radical nephrectomy for organ-confined renal cancer. The other causes of anemia that one could see for those patients who may even have metastatic disease, could be nutritional. From anorexia from the disease condition itself, nausea and vomiting, as a component of the wellness, or even from chemotherapy or medication use. Tumor-related blood loss, like I mentioned, the renal tumor could grow into the vessels, adjacent to the kidney and cause substantial hemorrhage, bone marrow spread, as commonly seen in prostate cancer, causing anemia. Obstructive uropathy that will cause renal failure and chronic anemia too is another important cause, especially for those tumors in the lower urinary tract. Sepsis, of course, either from tumor necrosis of lesions, that have been affected by cancer, and myelosuppression that will come from chemotherapy, inflammation of the cancer itself. Now, the pillars of bloodless surgery include doing all we can to optimize the patient's hemolytic rate. Preoperatively, if you have the opportunity to, and whatever one does, one must minimize blood loss, optimize tissue oxygenation, and then support the patient's physiological tolerance of anemia, as we'll get to see as we go on. Now, the principles here are what guide individualized patient management, when you have a patient who has a historical diagnosis of a tumor. And naturally, the trend is to take a history, get a physical examination done, do some confirmatory investigations to get a histological diagnosis where you can, maybe except with renal cell cancer. We don't routinely do renal biopsies to confirm renal cancer. And then you stage the disease, get a histologic grade, and then you can now prognosticate and define goals of management with each patient based on the stage of disease as diagnosis. So for patients who may eventually need surgery, if the disease is organ confined and you want to offer some radical treatment that will give the patient a chance at cure, patient most times may have earned surgery. So blood loss and associated transfusion, can be expected in many complex urologic oncology procedures, such as radical cystectomy, radical prostatectomy, penectomy, as I mentioned earlier. So it's important that careful patient evaluation and selection with a multidisciplinary approach is required for each patient to get each person the optimal outcome. The urologic oncology patient that refuses blood transfusion does present challenges in preoperative blood management. Therefore, a multidisciplinary approach involving the patient, his caregivers, in collaboration with the hematologists, anesthesiologists, nutritionists, the nephrologists, the oncologists, the nurses, and the urologists, using various techniques that are available in our local setting, are all employed in the preoperative phase, and also in metastatic disease where indicated, to minimize blood loss and also minimize any need for blood transfusion. So I'll be taking this preoperatively and then intraoperatively. So preoperatively, we carefully take a history, a medical history, physical examination, get histologic diagnosis, grade and stage the disease, and then we define our management goals with the multidisciplinary team involving the patient. And where it's applicable or where there's a chance to do so, we build up the hematocrit before elective surgery using erythropoietin and iron as indicated based on the baseline hemogram. Nutritional support and supplements are also instituted, such as iron, vitamin C, vitamin K, to improve patients' blood health generally. We also need to search for infection and treat it. We employ microblood sampling now, and we reduce unnecessary frequent tests, timing, request of blood investigation to be close to the time of interpretation or need for intervention. And then if there are any hemodynamic instabilities, hypooxygenation, tachycardia, tachypnea, all those need to be looked out for and corrected before surgical intervention where the chance presents itself. And then we also have to look out for clotting disorders in these patients and ensure that there are no unrecognized clotting disorders. Because these procedures usually are done around large blood vessels. So it's important that the patient be optimized in a wholesome manner. For those patients who may be on anticoagulants, it's important to find out and then carefully switch to what will be safe in the perioperative period. Intraoperatively, there's a wide armamentarium of things that can be done, instruments that can be employed to make the procedures safe for the patient. First of all, if a procedure can be done without the open approach, that's what one should offer the patient and refer the patient appropriately to where he can access minimally invasive techniques to do his surgical procedure. So where transurethral resection of the bladder tumor can be done, the patient should be given that option. For those who can have laparoscopic or robotic radical prostatectomy, same thing, laparoscopic radical nephrectomy should also be given the chance to access that form of care. Hypotensive anesthesia, as we've learned during the week, use of volume expanders, excuse me, please, and oxygen carriers intraoperatively. Hypothermia, where indicated, prompt and appropriate suture ligation techniques, use of tourniquet, where indicated, and appropriate patient position are all things that can be employed intraoperatively to limit blood loss. And then the judicious use of diathermy, lasers, sun scalpels to control bleeding intraoperatively. Also, things, use of tranexamic acid, intranasal supplementary oxygen, careful and gentle tissue dissection, use of clotting factor injections, infusions, or topical agents that will help stop bleeding from oozing sites, for example, and promote clotting at surgery are all things that can be done. There's also the use of intraoperative blood salvage, where one could perform acute normovolumic hemodilution, or use of extracorporeal circuits like is done during cardiopulmonary bypass surgeries, repair of great vessels. Like I mentioned, a number of our procedures in urology are done around very large blood vessels, which may get tragically traumatized. And then it's very important to promptly recognize and control source of bleeding at surgery to ensure hemostasis is secured and maintained before closing the patient up, and then the use of drains where applicable to ensure that there's no reactionary hemorrhage, when the blood pressure is returned back to normal after surgery and patient is out of the OR. So for the non-surgical causes of anemia, for those patients now who may have metastatic disease and may be candidates for palliative care. So their nutrition is something very key that one needs to focus on. Many patients have this conceived notion they mustn't eat certain things, so they're on a diet that puts them in negative nitrogen balance. So the tumor is eating away at them, and they don't have the physiologic reserve to tolerate the cachexia from the malignancy and the malnutrition that it imposed on themselves. It's also important to control sepsis, to relieve any urinary tract obstruction. Fluid and electrolyte balance is very important, especially for those patients who may take chemotherapy. And then control of any comorbidities the patient may have, diabetes, hypertension, employment or administration of hematinics, erythropoietin and iron use. And then instead of doing radical surgery for some times, there's some great stages of disease that hormonal therapy or immunotherapy are indicated, and those should be offered to the patient to control the tumor. Locally, I've had a number of patients who have managed without blood transfusion. I'll talk about a few of them. There's there's Mr. NT, who was clinically diagnosed with metastatic prostate cancer, stage T3, N1, M1B. So the tumor had spread to his spine and his left humerus. Now, I mentioned clinically diagnosed because this patient, for example, presented to me with renal failure. He came in renal failure from obstetric uropathy. The tumor had early obstructed both ureteric orifices, giving him chronic hydroureteral nephrosis that damaged his kidneys. He came in with an eGFR of 20 and PCV of 24, but he was septic at that time. We couldn't do a prostate biopsy, so we asked for an MRI, which was reported as a PIRADS 5. And because he was too unwell to have a confirmatory prostate biopsy at that time, in principle, I discussed with the patient and his nephrologist after several sessions of hemodialysis to manage based on the overwhelming clinical evidence we have as prostate cancer, and was put on erythropoietin, put on IV iron. He had IV antibiotics. He had nephrostomy tubes put in both the kidneys, and then it came out of renal failure. The eGFR now is hanging steady somewhere around 18. I will call it a steady state PCV now of about 20. And he seems to be tolerating that chronic anemia. Efforts to build it up, have been one step forward, two steps backward. He doesn't seem to manage the tubes very well. They keep falling out, so the kidneys keep having intermittent obstruction. However, the gentleman is still with us, and he's due for another tube recession when I see him next at the clinic. The next patient is Mr. AB, who had histologically diagnosed metastatic prostate cancer presentation, subsequently had surgical appendectomy in the form of hormonal manipulation, and the PSA dropped from 1,400 to 17 following the hormonal manipulation with the surgical appendectomy. However, 3 months after his appendectomy, he started having Malay. PCV check revealed the PCV of 18, excuse me. And so I commenced him on iron, erythropoietin, and right now, the PCV is back up to 26. However, he's been having these terrible bone pains, and so I've had to refer him to the radio-oncologist here for some radiotherapy to at least improve his quality of life. My next patient is Mr. AO, with histologically diagnosed metastatic prostate cancer. He, however, kind of went into denial after diagnosis and disappeared for about 3 months, represented with metastatic spread to the bones, came back in severe pain, and then he subsequently accepted the hormonal manipulation with opiectomy. Symptoms reduced a bit, however, the pains persisted, and by the time I referred him to the oncologist for a session of radiotherapy, pain reduced, and then he was booked for adjuvant chemo, cyclical chemotherapy. He, however, didn't tolerate the first episode and subsequently succumbed following chemotherapy. The next patient is Mrs. EF, a 61-year-old female who had a T2B NO MO left renal cancer, who subsequently had bloodless radical left nephrectomy, and she recovered uneventfully following surgery. Over the past year, I've been at the General Hospital. I've also had 6 diagnosed organ-confined prostate cancers. 4 of them opted for radical radiotherapy. 2, I referred to have radical prostatectomy done, and they also recovered uneventfully from that and didn't have blood transfusions during their surgeries. And all the 6 of them are currently still with us. And the benefits of having bloodless medicine techniques that the patients have, at least I've seen, they seem to have improved outcomes. If I was going to make an anecdotal conclusion from patients I've seen, the ones that eventually, got exposed to blood transfusion, either had some complication or their survival period kind of shut down. The first gentleman I mentioned, at least he he has been my patient in the last year, and I'm glad that he's still, he's still holding on and trying to live with the disease and get ahead of it as much as he can, So survival is something that most surgeons are not able to guarantee their patients, especially if they come with advanced disease. So for that gentleman, I think his non-bloodless care, multidisciplinary way between myself, the nephrologist, and the hematologist have contributed to his good outcome so far. And most research show clearly that patients who have bloodless care, they have fewer post-operative strokes, heart attacks, and other complications. There's no issue of blood transfusion reaction, and overall, they have more positive outcomes and experience of their treatment. There's also reduced infection rates, reaction rates, because when patients take blood, sometimes they develop a fever. They're not sure if it's from the disease process or it's from the blood transfusion or from malaria or something else in this environment. Okay, and for those who have allergic reactions, it leaves a bitter pill taste in their mouth afterwards. And then, of course, for those that can be having blood transfusion transmitted infections, which is not something any surgeon or hospital even wants to be associated with. It also saves time and money, also from the testament of some of the patients who spoke with us yesterday. The cost of getting a donor, screening the blood, administering the blood, is additional to the baseline cost of whatever care patient has to deal with while in hospital. Okay, and it also increases longer hospital stays because after they are transfused, or they have to wait for about 48 hours for equilibration, and they're going to check, have they corrected the anemia, so to speak, And for those who have rare blood types, the wait to search for a suitable donor, also increases in-hospital stay time and cost. And of course, in war or civil unrest, or when there are natural disasters, blood actually may become inaccessible. And these patients, will still need medical and surgical care that we can still deliver with the principles of bloodless care that have been outlined. In conclusion, knowledge and the application of the pillars and principles of bloodless medical and surgical care, they are invaluable to the uro-oncology patients as it gives them better outcome. Additionally, as physicians, it's important we also respect the rights of these patients who may refuse the use of blood, whether for religious reasons or choice or previous adverse reactions that they may have had while delivering to them wholesome care. Thank you very much for your attention.